Hello, this is Kim Jong-il. Today's lecture is the second part on expansion appliances, the various types of expansion appliances. Expansion appliances can be used on the maxilla or the mandible. When used on the maxilla, either fixed or removable appliances can be used. Expansion appliances can be divided into slow expansion or rapid expansion appliances. At slow expansion, dental effects can be observed and expansion is made gradually. The tissue response would be more physiological. It is light force, and the screw is activated 2 to 3 times a week. Therefore, the appliance is usually applied for normally 2 to 6 months. It can be divided into fixed type or removable type. Because it can be used at all ages and can be used for a long period of time, the likelihood of relapse is less than that of rapid expansion. On the other hand, rapid expansion may have orthopedic effects, resulting in the widening of the maxillary mid-palatal suture. Expansion is obviously rapid. A traumatic force is applied to the tissue. So, a strong force is applied. Screw activation is normally made once or twice a day for 4 weeks. Fixed appliances are mainly used, mostly on growing children. Because the expansion is rapid, the possibility of recurrence is great, so it must be maintained in the oral cavity for a long time after expansion. The expansion appliance includes an expansion screw. Each rotation creates 0.25 mm of space. The required space is usually 6 to 9 mm. How many times should we turn the screw to obtain 6 to 9 mm of space? The answer is 24 to 36 times. If we rotate the screw once a day by using RME, it should take 4 to 5 weeks, which is approximately a month. For slow expansion, we normally rotate the screw twice a week. To rotate a total of 24 to 36 times, it takes us 12 to 18 weeks. Therefore, the duration of application would be around 3 to 4 months. Dr. Hicks compared the effects of rapid and slow expansion. He compared the skeletal and dental factors. For rapid expansions, the effects appear quickly, but the skeletal effects tend to relapse over time. For slow expansions, the effects appear gradually. Recent studies have concluded that the effects of rapid expansion and slow expansion are approximately the same. Let's take a look at the rapid expansion appliance on the maxilla. Rapid expansion can be largely divided into Haas type and Hyrax type. And it can also be classified into bonded RME and 2 expansion appliances. The Haas type has a resin base in the expansion appliance, but the Hyrax does not. Haas type is significantly more effective regarding the degree of expansion. The maxillary maxilla can be sufficiently widened due to resin base. However, the disadvantages are that there may be food impaction between resin base and the palate, and that hygiene control is difficult. Hyrax is slightly less effective than Haas in the aspect of expansion, but it is easier to control oral hygiene. Therefore, I personally recommend Hyrax. For Hyrax, we apply bands on tooth 4 and 6. The arrow on the expansion screw faces backwards. The terminal molar or canine can also simultaneously be expanded by using extension arch wires up to tooth 7 or 3. Since the Hyrax is a fixed appliance, the patient cannot turn the expansion screw on his own. It must be turned by a guardian. If we insert the expander key into the hole in the front and push it to the rear, a new hole appears in the front. The expander key must only be removed after we make sure a new hole has appeared. Because tooth 4 and 6 need to be banded to use Hyrax, 4 and 6 need to be separated first. After banding tooth 4 and 6, take an alginate impression. Remove the band, place it on the impression, and pour plaster. Separate tooth 4 and 6 again, and deliver Hyrax at the next visit. There are several types of rapid expansion. One of them is bonded RME with a hook. We first cover the occlusal surface of the maxillary lateral tooth group and place a hook between C and D, or tooth 3 and 4. The hook is used to protract the entire maxillary skeleton during face mask therapy in Class 3 malocclusion. Secondly, we can use 2 expansion appliances. For 2 expansion appliances, maxillary tooth 4 is not banded, but tooth 6 is banded twice. In terms of therapeutic effect, bonded RME is more effective than banded RME. Because the bonded RME covers the occlusal surface of the posterior tooth, the PNS rises and the ANS descends. A major shortcoming of bonded RME is that it is difficult to control oral hygiene, which will likely result in dental caries. It is especially inconvenient when the maxillary first molar erupts and develops caries. This is why I decide the RME type, depending on whether or not the maxillary first molar has erupted. In the stages of deciduous dentition, bonded RME can be used. After the eruption of the maxillary first molar, I recommend Hyrax over bonded RME. Dr. Lamparski compared the skeletal and dental changes of Hyrax and 2 expansion appliances. Their effects on the mid-palatal suture, the dentition, the arch perimeter were not significantly different. Therefore, I recommend the 2 expansion appliances over Hyrax. The slow expansion of the maxilla can be largely categorized into SME slow maxillary expansion and quad helix. The SME is a removable appliance that inserts an expansion screw into the maxilla. Adams clasps should also be used together on tooth 4 and 6. I am going to mention more about this later, but we can cut the Adams clasps on tooth 4 to level and align the anterior dentition. The quad helix is a fixed appliance. There is a band on tooth 6 and 4 helixes towards the palate. The arch wire is inserted to match the palatal shape of the lateral tooth group. The removable expansion appliance used on the mandible is called the Schwartz appliance. I use the term SZ. As it is in the maxilla, it is recommended to apply Adams clasps on tooth 4 and 6 with the removable appliance on the mandible. The mandibular lateral teeth with slight crowding in the mandible may be lingually inclined. In such cases, we can upright and expand the lateral teeth by using an expansion appliance on the mandible. This will increase the arch perimeter, resulting in space to deal with the crowding. The changes in arch dimension on the mixed dental arch, depending on different expansion appliances, were compared. The control group experienced almost no increase of arch perimeter with 0.9 mm. However, the RME group increased by 4.9 mm, and the group with both RME on the maxilla and Schwartz in the mandible increased by 7.2 mm. The quad helix is bent using a 0.9 mm stainless steel arch wire. There is a banded maxillary first molar and 4 helixes. The quad helix has clear advantages and disadvantages. The advantages are as follows. The retention is good because it is a fixed appliance. Patient cooperation is unnecessary. It can be used for various purposes. It has orthopedic effects compared to removable appliances. The left and right sides can be expanded separately. There is less relapse. Using brackets simultaneously is possible. Molar rotation and torque adjustment is possible. The price is not so expensive. The disadvantages are as follows. It will be molar tipping and bite opening. Skeletal effects may be limited. This is how we initially activate. If we engage after expanding the wire of region number 6 on the model, the lateral tooth group will widen, and the first molar will derotate and expand. From the patient's next visit, we can adjust it in the oral cavity. We use 3 jaw pliers when adjusting in the oral cavity. We can position the 3 jaw pliers like A or B. What would happen if we place the 3 jaw pliers like B? If one plier's beak faces backwards due to the 3 jaw pliers, region tooth 6 narrows as such. This should not happen. What we must remember is that the 1 plier beak of 3 jaw pliers should face forward. This will expand region tooth 6. Then, to expand the lateral tooth group, place 1 plier beak of 3 jaw pliers on the palatal side to activate. When performing intraoral activation, we must consider the direction of activation. There are several modifications to this expansion appliance. Anterior expansion can be done, and the simultaneous uses of anterior bite plate, PBB, Schwartz and PBB in the mandible, and 3-way expansion appliance are all possible. We can use SME PBB. Why should we cover the posterior area? When the palatal cusp falls as the maxilla expands, it is enlarged, but the mandible rotates posteriorly and downwardly. To compensate for this, we should cover the posterior area. For cases of Class 3 malocclusion with linguoversion at the maxillary incisors, the anterior region of the maxilla should be moved labially. In this case, PBB is used simultaneously to eliminate the occlusal force. It is recommended to push the entire premaxilla forward by using an expansion screw instead of a finger spring on the anterior region. I call this the anterior expansion plate AEP. The slow expansion appliance used on the mandible is called a Schwartz. It can cover the posterior area, and this is called Schwartz PBB. For cases of deep bite, we can use expansion appliances simultaneously using the anterior bite plate. This can be used when the lateral tooth group is lingually inclined and is a deep bite. The bite is raising, and the lateral tooth group is expanded sideways by the expansion appliance. This is called anterior bite plate SME. For cases of full arch crossbite, we can expand in 3 directions forward, left, and right. I personally did not find this very effective. So if 3-way expansion is needed, I expand laterally first, followed by forward expansion. What appliance should we choose for expansion? The first point of consideration would be the age. Is the patient's dentition in the deciduous stage or mixed stage? Is he/she an adolescent or is an adult? Another point of consideration is the amount of expansion required. It is necessary to determine whether or not the patient is buccally normal, has lingual overjet, has unilateral crossbite, has bilateral crossbite, etc. Whether or not the terminal molar has crossbite is an important factor. If the terminal molar does have crossbite, a rapid expansion appliance must be used. We can use rapid expansion appliance RME and strategic leveling on growing children. We can RME through mini screws for adults. Even if there is no crossbite on the terminal molars, tooth 4, 5, 6 could be. If the maxillary arch is narrow, a rapid enlargement appliance must be used. For cases where the maxillary dental arch is not narrow and the lateral tooth group has no crossbite, we perform slow expansion and strategic leveling. For cases where neither the terminal molars nor the lateral tooth group have crossbite and the dental arch is not narrow, we only perform strategic leveling. For strategic leveling, the dental arch should have a normal shape and there must be no posterior crossbite. It is best when the TPW is normal and the terminal molars are mesially rotated. For SME, cases with a V-shaped arch form, no posterior crossbite, normal TPW and mesially rotated molars are preferable. Rapid expansion is recommended to be performed during the growing stages. Rapid expansion is used for cases with narrow TPW or posterior crossbite. MARPE, mini screws, assisted rapid palatal expansion is used for adult patients, patients with posterior crossbite, and patients with narrow TPW. How do we activate the expansion appliances in this case? The SME and SME PBB should be rotated 2 to 3 times per week. They are usually turned twice. The Schwartz and Schwartz PBB used on the mandible are rotated once or twice a week. The Hyrax or 2 expansion appliance should be rotated once a day. MARPE should be also rotated once a day. The MSE is rotated twice a day because one rotation only expands a small width of 0.13 mm. Thank you for watching.